So now you will listen to what your peers are doing. So we're going to listen to MD, PhD research from your colleagues from different countries. For all of you, there will be 7 minutes talk and then 2-3 minutes questions. So let's try to do each talk little questions afterwards. Otherwise, it gets too messy. So do we have the presentations? Clara, where is she? Clara. Do we have the list of the presentations? Did you make it in order? Yeah. Out of it. I have a list, but not here. Where is it?
I don't have the lot.
Okay.
Do two of yours.
Okay, start. So the first student to present will be Federico Regimota, who is going to present us the iPSC's technology, a promising tool for the modeling of treatment-resistant depression. Thank you, Federico.
Good afternoon, everyone. So good afternoon again. I am Federico Motta, and I got my degree in medical school this year in Università Bicocca. And I basically researched for 2 years long the technology IPS and its role in the modeling of neuropsychiatric disorder. In particular, we focused on TRD, so treatment-resistant depression, and we also gave a focus on the mechanism of action of esketamine, which is like an antidepressant, and their compounds. So I want to basically show the translational project, which basically was done with the help of 3 different labs or 3 different departments. The first one was definitely the clinical part, focused on the Ospedale San Gerardo in psychiatry department, in which we basically recruit patients with TRD, so treatment-resistant depression. And then we had 2 collaborations with Cibio in Trento, which basically focused on the reprogramming process. So taking patient cells into stem cells. And then the third part that was done with the collaboration with Dr. Carlo Sala at the CNR, so Consiglio Nazionale delle Ricerche, in which basically we did the differentiated process, so from stem cells to neuron cells. So basically, I just want to give a brief focus on TRD. So TRD is basically a clinical feature of depression, but it's a really strong and tough disease because basically is considered as the failure of 2 different antidepressants therapies, in which the drugs have been taken for an adequate time and a correct dose, because this is a clinical feature that is very difficult to manage, first of all, because it represented 30% of patients treated with antidepressants, and moreover, it can be considered to affect people that will develop a chronic illness. So it's a little bit different from what we know about like normal depression or like the depression that can be reverted with just like 1 cycle of antidepressant drug. So linking to the clinical part, we can see that the FDA basically and also other regulatory pharmacy so EMA and FDA, sorry, I cannot say English, approved the use of esketamine nasal spray for the treatment of TRD in 2019. And basically, we had a recruitment of 20 patients in Ospedale San Gerardo, also in collaboration with Ospedale San Raffaele and Statale di Milano, in which we started the therapy with esketamine spray. What I really want to say very quickly, the mechanism of action of esketamine is not really well known, but it has to be considered as to improve the release of BDNF, which is an important neurotrophic factor that can help in the neuroplasticity. So in general, esketamine is not linked to a modulation of serotonin transporter or noradrenaline transporter, which is like what is common for SSRIs, but it works in a completely different ways. And you can see in the top picture how the mechanisms of action are wide and basically very, very difficult to understand and to monitor. But the starting scientific point was that we saw that in depressed mice, the infusion of ketamine increased the neuroplasticity and increased the number of synapses in the synaptic cleft. So starting from this finding and starting from the approval of esketamine, we basically faced another problem. So the problem was based on how can we relate and how can we model a neuropsychiatric disorder in animals. So they basically have some limitations, and the environmental factors are basically different from the humans ones. So we had this question, and the answer came from the use of IPS, so human-induced pluripotent stem cells. And starting with these new technologies, we basically try to set the protocol to reprogram the cells, so from mature blood cells going back to the stem cell stages, and then we had to set the differentiated protocols from stem cells to neurons. And then we wanted to know how to model TRD in vitro, so avoiding the use of animals which we said are not enough, and they have so many limitations. And last part of the work will be focusing on the mechanism of action of ketamine that will be administered in our IPS culture. So as I said, the program, the research work was divided into 3 different parts. So the first part was the clinical part, the one that I basically start focusing on. So we had the recruitment of patient, the one diagnosed with TRD, and then we basically followed them up for the starting date, so November 2020, and it's still ongoing because we're still recruiting new patients. And we wanted to first define the efficacy and the tolerability of the drugs, and then we had to basically stratificate the patient into responder and into non-responder, so people that basically reverted from TRD and people who didn't. Then, starting from the stratification, we basically generate IPS stem cells with the help of the Cibio lab. And the part that I basically I had been able to focus more on was the differentiating process. So from stem cells to derived neurons. And the focus of the work is basically there because we had been able to had glutamate neurons, and we're still trying to work on different aspects. So we're doing morphological, physiological, and transcriptomic analysis. So to model TRD and then to try to understand something more about ketamine. And that's basically like a very quick overview because the work was basically very long, and I'm trying to just gather some pictures from the work we did. So first of all, we got IPS technology from patient blood cells, and then we basically had been able to create IPS. And we also characterized them, and we saw that they were definitely able to express pluripotency genes, From them, we basically went through embryonic bodies, for which I don't have the picture, and from then we had rosettes. So rosettes are the first morphological part that can be linked to the neural tube. So we had been able to understand that our stem cells were able to start the differentiation into neurons or neuronal progenitals, as we can see in the fourth image. And the second part of the protocols basically define which protocols was better to obtain glutamate, so excitatory neurons, and we finally had been able to find the right protocol. So we had, after 50 days, mature glutamatergic neurons expressing MAP2 and DAPITs for just like the survivability of the neuron itself. And we also focus on the synapses, and we saw that the dendrites, so the sort of dendrites of our obtained neurons were basically expressing PSD95, which is a protein expressed in the synapses. So we basically had been able to obtain neurons from mature patient blood cells. What we're doing at the moment is basically trying to understand what kind of proteins are more expressed after ketamine infusion. So we take our induced neuron and we administer some ketamine, and we're trying to classify what kind of proteins are involved. The experiment is still going on, but we start seeing an overexpression of the factor EF2, which is definitely linked to the pathway stimulated by ketamine infusion. So we are somehow able to see something also in our induced neurons. So it was a very wide research, so I don't know if I really gave it the right spots, but anyway, what was the goal of this research? First of all, to set the two different protocols. So obtain IPS from patient is difficult, and obtain neurons from stem cells is still more difficult. So we had been able to have neurons that are somehow functional, and we want to make sure with future electrophysiology analysis. And also we are trying to set another protocols for differentiation stem cells into GABAergic neurons. So to complete the synaptic cleft involved in the basically ketamine mechanism of action. Another point of view is definitely under the clinical part, which I didn't really give any details for a lack of time, but we saw the ketamine is efficient in treating TRD, and we want to have more information about the long-term use of it, because we're still working on the short-term effects. And basically, that was all, and I want to thank you all the parties in the research, as you saw in the first picture. So we work with two different labs in the clinical department in San Gerardo Hospital. If you have any question, I didn't focus on the molecular part because it was too intense, but if you have any question about that, I will try to answer it. Okay, thank you.
So our next speaker is Lara Steiger from the University Hospital of Basel. She's going to speak to us about inflammation. The exocrine pancreas impairs insulin secretion. Thank you, Laura.
Could I send you a mail? Do you have it? Okay.
Do you mind just presenting afterwards? We'll bring your presentation here. We will move to the next one and come back here. Christoph Affelfinger will speak to us about mesenchymal stem cell-derived exosomes, decreased levels of pro-inflammatory cytokines IL-6 and IL-1, alpha released from LPS-stimulated microglia, potentially by delivering proteins of the Nexin family. It's coming from University Hospital Basel. Thank you, Christoph.
Okay, perfect. So this morning you heard already about mesenchymal stem cells from Professor Citerio. So he's doing clinical studies while we are moving back to preclinical studies with exosomes from mesenchymal stem cells. So let me introduce you to the disease we are studying at our lab. It's not a traumatic brain injury, but it's neonatal hypoxic ischemic encephalopathy. So it's a disease that's pretty common with around 1 to 2 per 1,000 term-born babies. And currently the only treatment option is hypothermia. You can see it on the picture also. So we put the babies at 33 degrees Celsius for a total of 3 days. And that's currently the only option we have. And as I already said, the benefit is very limited. So the hallmark of the disease actually is microglial neuroinflammation. So this picture is from our lab. On the left side, you can see a mouse who didn't have a stroke. On the right side, you can see a mouse who had a stroke. And CD68, so in yellow, you have a marker of inflammation. Exactly. So that was just to show that. And currently, as Professor Citerio already told you, there's a new promising approach for treating brain injury, and that's the transplantation of mesenchymal stem cells. So with mesenchymal stem cell transplantation, as he already told you, there is, in preclinical and some clinical studies, there has already been shown an improved motor income, and also a decrease in inflammation. But what's surprisingly is that we don't really know how this mechanism of action actually is performed, because most of the transplanted cells end up trapped in the lungs and don't get to the brain and don't home to the brain as previously thought. And that's exactly where the next hypothesis comes in. So it is believed that the function of the mesenchymal stem cells is mediated by exosomes, which are small nanolipoparticles containing proteins, DNAs, and RNAs, which can deliver these molecules in a paracrine or endocrine manner. And they can also cross the blood-brain barrier, which of course is very important in this context. So then, for the aims of this study, firstly, it is to investigate the effects of these exosomes on a model of neuroinflammation. Secondly, to explore the content of these exosomes. And thirdly, to identify potential mediators of those effects encapsulated in those vesicles. And lastly, if I have the time to do it, I would love to test on suspected mediators and to find potential new treatments. So here, just a very brief overview of the methods that we are using. So we have 3 different donors, and we use the umbilical cord derived mesenchymal stem cells. So what I do with those is I expand them and then use the conditioned media, which I sequentially ultracentrifuge at 100,000 G to obtain the exosomes, which you can see on the picture. And then what we did was 2 different types of experiments. First, the neuroinflammation model with a LPS stimulation of the microglia, and later on I then analyze the cytokine secretion by ELISA. And secondly, what we did was mass spectrometry to analyze actually the contents of those vesicles. So next up for the results section. Firstly, I have to mention that the data is preliminary. It's very recent, very new, so not for all I have good replication numbers yet, but mostly it's in line with previous research. So here for IL-6, you can see a clear dose-dependent decrease of the pro-inflammatory cytokine, depending on whether I have used 1 microgram per ml of exosomes or 10 micrograms per ml of exosomes, and it's highly significant. We see a similar trend for interleukin-1 alpha. However, for TNF alpha, surprisingly, we see very little change. So next up for the results of the proteomics, among the top 20 proteins present in the exosomes, there were 2 which especially stood out because they might have these anti-inflammatory properties. So it's annexin A1 and annexin A2, which are both calcium-dependent phospholipase inhibitors, as well as annexin A1 being an anti-inflammatory activator of formal peptide receptor signaling. Also, interestingly, we found a lot of glycolytic enzymes. In fact, all of the enzymes of the canonical glycolysis pathway, and also calcium channels, among them calcium ATPases, which might be beneficial for the calcium-dependent phospholipase inhibition. So here, just to give you some context, this is the annexin A1 formal peptide receptor axis, and as you can see, it basically inhibits very important hallmarks of inflammation as reactive oxygen species production, NF-kappa B activation, and also apoptosis. So lastly, I would like to give you an outlook. So first of all, I'm currently working on the replication, and we would like to analyze more cytokines, doing a cytokine array. We are also interested, of course, in the secretion of anti-inflammatory cytokines. Next up, I would like to investigate the annexin A1 formal peptide receptor axis using a commonly used inhibitor of the receptor. And lastly would be maybe more on a visionary note, would be to engineer nanolipoparticles as they are, for example, employed in the COVID vaccine. You might note this. But these nanolipoparticles could be transfected with annexin proteins, as you can see in this citation. There are people who already have done this in different models. So we think we could apply this and create ultimately a new therapeutic approach for neonatal hypoxic ischemic encephalopathy. So for the conclusions, it's more of a repetition again. So firstly, I hope I was able to show you that human umbilical cord MSC exosomes are able to reduce microglial inflammation. Secondly, that annexins A1 and 2 might be the potential mediators of these effects. And lastly, that engineered nanolipoparticles could represent a novel therapeutic approach to neonatal HIE. And that's also the vision that I have, or I would like to convey to you. The science could go in a direction that engineered nanolipoparticles could be a novel, precise, and predictable anti-inflammatory therapeutic. And it's also subject in cancer studies as well, where some compounds can also be encapsulated in such nanolipoparticles and then administered directly. So with that, I would like to close, and thank you very much for your attention. I'm ready to take your questions.
What trigger the microglia have, and is it possible to use that in your studies?
Yeah, so it's a very valid question that I asked myself as well. So there are two approaches to this question. The first is that the LPS model is a very common neuroinflammatory model, which is commonly used. Of course, it's not, as you say, it's maybe not the most logical approach to a sterile model of neuroinflammation. However, in neonatal hypoxic ischemic encephalopathy, you also have a lot of damage-associated proteins, which can also activate toll-like receptor signaling. And LPS actually is an activator of toll-like receptor-mediated inflammation. More specifically, TLR4 and 6, I believe, which can also be activated by damage-associated proteins. So while it might not be the perfect model, I still think it has some merits to it. And there have been some, basically the preclinical research in animal models which has been done. There people did LPS models with mesenchymal stem cells, and also did stroke models for neonatal hypoxic ischemic encephalopathy, and basically there was the same trend. So there didn't really matter what kind of model you used, you would get to a similar result, and that's why we chose to go for this very easy and also very much reproducible approach.
Thank you so much.
Thank you.
So we are welcoming again Laura Steiger. I have newly settled the problem. Just waiting on the scan this. There it is.
Perfect.
Looks like the one.
Yes. Okay. So, hi everyone, I'm Laura. I'm a MD PhD student in the Diabetes Research Lab of Mark Donat in Basel, so from Switzerland. And thanks to the organizer, I'm really happy to be here and also talk to you, because normally I'm working with mice and they are normally not so amused about my company. So the title of my presentation is Inflammation in the Exocrine Pancreas Impairs Insulin Secretion. So a quick recap. Functionally working beta cells reacts to glucose with insulin secretion. In type 2 diabetes, increased glucose and free fatty acids are present. This leads to a recruitment of immune cells, predominantly macrophages via chemokines. And these immune cells secreted cytokines, for example, IL-1 beta, and this leads to an inhibition of insulin secretion. So, in summary, islet inflammation is present in type 2 diabetes. We and others have now observed that patients with type 2 diabetes have also an increased number of immune cells in the exocrine pancreas and not only in the islets. The effect of these immune cells in the exocrine pancreas on endocrine function is until now unclear. So, and a further observation is that inflammation in the exocrine pancreas in humans, for example, chronic pancreatitis, is associated with endocrine dysfunction. So this leads us to the thinking that maybe the immune cells from the exocrine pancreas could play a role in the pathogenesis of diabetes, and that there may be mechanistic links between the pancreatitis-induced or the pancreatitis-induced diabetes and type 2 diabetes. Therefore, we hypothesize that immune cells and their microenvironment from exocrine pancreas impair insulin secretion. So, to follow or to study this hypothesis, we have three specific aims. The first aim is, of course, to establish a mouse model, and there we want to have a mouse model with exocrine inflammation with secondary endocrine dysfunction. So I'm very happy I have some data to show to you. The next aim will be to characterize the immune cells and the microenvironment in the exocrine and endocrine pancreas of the mouse model. Now they are working on. And the interesting part will be to study the link between immune cells in the exocrine pancreas and beta cell function. So that's my goal I'm running for. So over the last 2 years, I could establish a chronic pancreatitis mouse model. The experimental setup looked as follows. At the age of 6 weeks, the mice received high-fat diet for 6 weeks. To achieve an inflammation in the exocrine pancreas, we used sertraline, which is a cholestyrocytokinin receptor agonist widely used to induce chronic pancreatitis pharmacologically. In addition, sertraline also inhibits the appetite. This is the reason why we single-cage the mice and we food restrict our control mice to avoid a too big weight difference between the two groups. So we inject sertraline or saline as a control every second day for 3 weeks. 3 days after the last injection, we perform the glucose tolerance test and then sacrifice the mice for histology or ex vivo experiments. So to study the metabolic phenotype, we performed a glucose tolerance test. After 6 hours of fasting, we inject a glucose bolus, IP, and measured the glucose and insulin at starting point 0, 15 minutes, and 13 minutes after the glucose bolus. We continue to measure the glucose up to 2 hours. Here you see on the left graph that the sertraline-treated mice show an increased glycemia compared to the saline-treated mice after the glucose bolus. In addition, in the middle, you see that the insulin secretion is decreased in our sertraline-treated mice compared to the saline-treated one. So that means we have a beta cell function, or that the beta cell function is impaired in mice with sertraline-induced pancreatitis. And most important, the weight is the same because glucose is dependent on the weight. To further study if this beta cell function impairment is still present when we remove the islets from the inflamed milieu, we performed a glucose-stimulated insulin secretion test, ex vivo. So we isolate the islet, we culture them for overnight, and then we stimulate the islets with low and high glucose. Here you see in this graph that the total amount of insulin is decreased in the islets of our sertraline-treated mice. And what you also can see is that the islets from the sertraline-treated mice show a decreased insulin secretion compared to the saline-treated mice after glucose stimulation. So also we have here a beta cell dysfunction. So to summarize, circulating glucose level and insulin secretion was decreased after glucose bolus in sertraline-treated mice. Decreased insulin content and stimulated insulin secretion in mice with sertraline-induced pancreatitis. So to conclude the whole story, inflammation in the exocrine pancreas leads to impaired islet function. So what I'm working on, and I will further do, is to characterize the immune cells and the microenvironment in exocrine and endocrine pancreas. And the aim will be to study the link between immune cells in the exocrine pancreas and beta cell function. And I want to thank you, and I hope your batteries are not too empty. Otherwise, I think we have a dinner, and you can refill your batteries. And, of course, I want to thank my lovely team and all the people who are involved in the project, especially the core facilities. Do you have questions?
This is a very tricky question, but if there is indeed a link between the inflammation in the exocrine pancreas and the function of the endocrine pancreas, do you think there is a potential way of targeting that inflammation to improve the inlet function?
I mean, it's really difficult to say. And it's also, I mean, I think it's more about to understand how the pathological of the diabetes is working. And until now, I mean, the people don't suffer from with the type 2 diabetes who have, for example, exocrine dysfunction don't suffer from them. But I think it's always critical to have, because the diabetes is in the end a really systemic disease. And maybe with anti-inflammatory treatment, you can start to treat them. That would be my suggestion.
It was a very tricky question, I understand,
yeah.
because we were speaking about the molecular mechanism behind the dysfunction of the
Yes.
inlet, and I was asking you how could we target it?
Yeah.
It's very hard, because all the time it's like it's an anatomical unit that's together with inlets inside exocrine parenchyma. But it was just to have, if you have any hint.
Yeah,
of,
so when you would
implications.
ask my boss, he would probably say anti-L1 beta treatment.
Thank you. Thanks so much.
One more question. So for the model, it was like an overfeeding model. For the mice, you gave them like lipids before, and they gain weight. And then you did the thing with chronic pancreatitis.
Yes.
My question is, for example, if they lose weight,
They lose weight. I mean, that's why. I mean, it cost me quite a lot of time to. I mean, with Cereline, it's really. I mean, it's also written in the literature, and you really see it that they stop to eat. So the Cereline, at first one, the Cereline inhibits the appetite, and the second one, I mean, they have pain. I also treat them with a painkiller, but you can barely see the mice suffering, right? So that's why they are losing weight. Was this your question? Yeah.
Actually, it was what's happening after losing weight with the process.
Wait, what's happening?
Yeah, after losing
The
weight.
problem is a little bit. That's why I show the weight graph. When you study metabolic phenotype, you want to do a glucose tolerance test, and it's really, the glucose is really dependent on the weight. So before then, I have just my saline. They don't lose weight, right? They gain weight normally, and the Cereline treated mice, they lost weight, and then I see also the insulin was decreased, but the problem is then you can also say, okay, they lose weight. That's why they have an improved glucose, or that's why the insulin is decreased.
Thank you so much, Laura. Our next speaker is Martina Paredi, UNIBIB. She's going to speak about immune monitoring in patients with relapsed B-cell precursor acute lymphoblastic leukemia treated with CAR-6 CD19 cells, impact on disease remission and clinical outcome. Thank you so much.
Thank you. Hello to everybody and good afternoon. My name is Martina Paredi. I'm a medical doctor from University of Milano Bicocca. I actually graduated in June, and the project I'm going to present you is my thesis project. So I hope you like it. Its title is Immune Monitoring in Patients with Relapsed B-cell Precursor Acute Lymphoblastic Leukemia treated with CAR-6 CD19 cells, which is an innovative drug, impact on disease remission and clinical outcome. Okay, so this study was an observational study in which patients were followed up to 12 months after the infusion of the drug. In particular, the study involved both pediatric and adult patients. Pediatric patients were followed at the pediatric clinic of the University of Milano Bicocca in Monza, while adult patients were followed at Hospital Papa Giovanni XXIII in Bergamo. The focus of this study regards acute lymphoblastic leukemia, ALL, and in particular it focuses on the most aggressive forms of acute lymphoblastic leukemias, which are the relapsed or refractory forms of this disease, because mortality is still very high in such forms of ALL. And to overcome such clinical challenges that this disease still poses, immunotherapies are born to resolve this problem. And in particular, among immunotherapies, these new therapies of CAR-Chick CD19 cells was developed at University of Milano Bicocca, in particular in Laboratorio Tettamanti and all the Comitato Maria Letizia Verga. CAR-Chick CD19 cells consist of T cells engineered through a non-viral transposon system, which is the Sleeping Beauty transposon system. And these cells were differentiated towards Chick cells. And to assess whether this product, this drug, was safe and effective, in 2017, a phase 1/2A clinical trial was established in the pediatric clinic of Milano Bicocca, but also in Hospital Papa Giovanni XXIII in Bergamo. And the patients that had a relapsed or refractory form of ALL underwent a donor-derived CAR-Chick CD19 cells infusion. This trial had a dose escalation scheme, meaning that some patients were treated with low doses of the drug, while other patients were treated with high doses of the drug. The aim of my study regarded such populations, so patients with relapsed or refractory forms of ALL that underwent donor-derived CAR-Chick CD19 cells infusion. In particular, my study was an immune monitoring study. Parameters such as the following that you can see in the slide, like the tumor burden after lymphodepletion, so before infusion, meaning the level of disease, but also minimal residual disease, which is a very important marker for the clinical outcome. Parameters related to CAR T cells, so their kinetics, phenotype, and the persistence, but also the level of normal B CD19 positive cells. And we decided to see if such parameter correlated with specific clinical outcomes and endpoints. The idea under this study is to understand better how CAR T cells, in particular CAR-Chick CD19 cells, but in general all immunotherapies, works in vivo. This is very important because it may lead to a more tailored and personalized approach to therapy, which is very important, especially nowadays, because personalized medicine is a really topic of interest. In the study, 27 patients were involved. In particular, there were 5 pediatric patients and 23 adult patients. 21 patients were patients from the clinical trial I have described before, while 6 patients were enrolled off protocol, so were not in the trial. The parameters were collected, were measured both in the peripheral blood and in the bone marrow, so different samples were collected from the patients, and were measured both through PCR, so real-time PCR, and through flow cytometry. We wanted to see the correlation between these parameters and clinical endpoints that were the overall survival with sensor data, the duration of response, but also the clinical status, meaning if the patient was dead or alive at 6 months after infusion and at last follow-up. The MRD status, so if the MRD was positive or negative at 28 days after infusion and at 6 months after infusion, and if the patient reached complete remission from the disease at day 28 and after 6 months from infusion. The results were very interesting, in my opinion. We found out that the MRD is a very strong clinical predictor of the outcome, and in particular it correlates with, when measured at day 28 after infusion, it correlates with overall survival and overall survival with sensor data. Regarding the tumor burden, we found out that it correlates with different parameters. In particular, the higher the tumor burden, the lower the overall survival with sensor data, the lower the probability to reach complete remission at day 28 after infusion, and to be alive at 6 months after infusion. In addition, the higher the tumor burden, the higher the CAR T cell peak. Regarding CAR T cell persistence, we found out that when CAR T cell persistence is measured as VCN, so vector copy number, so it's measured by PCR, it correlates with the duration of response to therapy. Moreover, we also made an analysis regarding the immunophenotype, and we found out that a predominantly cytotoxic phenotype correlates with, when measured at peak day, CAR T cells peak day, and at day 28 after infusion, correlates with lower levels of MRD, rather than predominantly helper phenotype. So this study was important because it helped us understand that the idea of immunological monitoring is very important in patients that underwent CAR T cells therapy in general, but also in particular CAR-Chick CD19 cells, which was the drug we used. And this is important because, as I said previously, it may help in clinical decisions, since it may be able to make a focus on such parameters to assess whether there is the possibility to cure and so to predict clinical outcomes. I want to thank everybody, especially Dr. Giuseppe Gaipa, which helped and guided me throughout these adventures, and also all the people in the Laboratorio Tettamanti and Comitato Maria Letizia Verga. Thank you for the attention.
Thank you. We have time for one brief question. We pushed one before, so I will give her the priority.
So, what are the differences between CAR-Chick CD19 cells and general CAR T cells, and why did you choose especially CAR-Chick in the therapy?
Okay, thank you for the question. It's a very interesting question. There are in the field of immunotherapies different types of CAR T cells that can be very different basing of their structure, their application, etc. CAR-T CD19 are a peculiar type of CAR T cells that are directed toward CD19, which is an antigen expressed by the leukemia. So these cells are target leukemia cells and hopefully destroy them. This product is innovative because it uses the for the construction of these cells, it uses a non-viral transposon system. So if generally CAR T cells are constructed using viral vectors, this way, using this type of transposon, there is the advantage to avoid all the negative aspects of viral vectors. And moreover, this product is peculiar because it is allogenic. Generally, CAR T cells are made from exactly, so from T cells that can be of the patient, generally, but in this case, they are donor-derived. And also, for this aspect, there are advantages. And so, this product was approved, and clinical trials are still going on to assess whether there can be real advantages in terms of safety, but also efficacy, and actually there are, so trials are going on. So. Yes, it was one of the reasons why it's an advantage. Yes, thank you. Okay. So thank you.
I think there might be some further questions, but we can discuss afterwards in the coffee break, so we keep tight to the agenda, okay? Next speaker is Anna Ciobanu, that is going to speak to us about the role of intraoperative endocyne in green fluorescence and geography to assess anastomotic perfusion following rectosigmoid resection in situ reductive surgery for advanced epithelial ovarian cancer. Thank you so much.
Hello, everyone. My name is Anna. I'm a student from Università Statale di Milano, and I will be presenting the study that I performed, which is the role of intraoperative endocyne in green fluorescence and geography to assess the anastomotic perfusion following rectosigmoid resection in cytoreductive surgery for advanced epithelial ovarian cancer. This is a short overview of what I will be talking about. And as a small introduction, I would like to say that the use of intraoperative endocyne in green fluorescence and geography in the assessment of anastomotic perfusion after bowel resection has been widely increased in the last years. It's a technique that consists in the peripheral administration of endocyne in green. Afterwards, an infrared camera captures the pictures that are then displayed on a screen, and so the surgeon can objectively assess the vascularization of the district of the interest. However, few data are available on its use for ovarian cancer surgery. For what regards ovarian cancer epidemiology, it's worth saying that it is the most lethal gynecologic malignancy. More than 70% of the cases are already advanced stages at the diagnosis, and less than 45% of patients survive at 5 years. For what regards the etiology, epithelial ovarian cancer arises from the surface epithelium stroma, as shown in the picture, and it can be divided in different subgroups, but 90% of this subtype are high-grade serous carcinoma. The treatment primarily includes surgery and chemotherapy with two alternatives, either primary surgery followed by adjuvant chemotherapy or neoadjuvant chemotherapy followed by interval surgery. Moreover, the use of maintenance therapy is recommended in both situations. It is worth saying that primary surgery is followed by chemotherapy has been the gold standard for the last 40 years. and the surgery is aimed at providing tumor debulking as well as histopathological diagnosis, and so it's a very important step in curing this disease. Ovarian cancer surgery is, as already mentioned, the disease is already advanced in most of the cases at the diagnosis, and so the debulking surgery includes the removal of a lot of structures, and in like 40% of the cases this involves a diaphragmatic resection, in 15% of the cases splenectomy, but a rectal sigmoid resection is performed in 50% of the cases. And as you can imagine, this is a very high percentage of people. Tumor debulking involves virtually any structure in the abdominal cavity, and this can lead to virtually complications in every body system. But for what regards the rectal sigmoid resection being performed in 50% of the cases, the highest risk is represented by an anastomotic leak. An anastomotic leak is a pathological communication in between the lumen of the hollow viscera and the peritoneal cavity. It is a frighteningly common complication, and it was documented to occur in about 10% of colorectal cancer patients. However, its incidence in ovarian cancer population varies in between 1 and 9%, and there is a rather limited published evidence on its risk factors. And so the aim of my study was to assess the impact of indocyanine green fluorescence angiography in reducing anastomotic leak after colorectal resection during primary cytoreductive surgery for advanced epithelial ovarian cancer. I retrospectively identified the patients undergoing this type of surgery during cytoreductive surgery for ovarian cancer from January 2009 to December 2021 at the Surgical Gynecology Unit of European Institute of Oncology. All clinical data I collected were from the medical records, and then I analyzed them with Microsoft Excel software and REDCap. The use of ICGFA to test the vascularity of the anastomosis was introduced in January 2020, and that was following a well-defined protocol applied to all consecutive patients. I will not explain the protocol because that would be too technical, but if some of you are interested, I can gladly explain it later on. The patients with rectal sigmoid resection were then selected and divided in two groups. A group in which the indocyanine green was used, and another group in which the ICGFA was not used in order to assess the perfusion of the anastomosis. My results included a total of 439 patients, out of which in 118 of them the ICGFA was used. In the remaining 321, we didn't use the ICGFA. We wanted then to analyze if were these two groups of patients homogeneous in between themselves, or were there any bias in between the populations that could alter our results for what regards the anastomotic leak. But as shown by the p-value in the statistical analysis, there were no significant, statistically significant differences for what regards the parameters that we decided to analyze. Out of 439 patients that we selected, 27 of them had an anastomotic leak, with 2 cases in the arm using ICGFA and 25 cases in the arm in which the ICGFA was not used. We then performed an univariate analysis, and for what regards the age, the albumin, the hemoglobin, platelets, CA125, it was shown that these factors did not influence the appearance of the leak, as well as the addition of a second small bowel resection or another bowel resection not at the level of the rectal sigmoid junction did not influence the appearance of the leak. The curious thing is that residual tumor, surgical time, were independent predictors of the appearance of the leak, while the use of ICGFA was an independent protective factor. Then we performed a multivariate analysis to actually check if this was the case, and we can see here that the surgical time remains still an independent predictor, while the residual tumor no longer is, and our assumption was that probably the patients that had longer surgeries actually had a higher burden of disease. And so that's why the surgical time is actually critical in predicting if there's going to be a leak or not, while the ICGFA still continued to remain a protective factor. We can also say that the patients in which the ICGFA was not used had a 4.66 times higher rate of leak compared to the patients in which the ICGFA was used, as shown by the odds ratio here. And so my conclusions are that the use of transabdominal indocyanine green fluorescence for the assessment of the rectosigmoid anastomosis perfusion, it is a safe, replicable, and effective technique. It allows for an objective evaluation of the anastomotic perfusion, which is of paramount importance in OR decisions. The use of ICGFA was associated with a decrease of rectal sigmoid leak in patients undergoing primary cytoreductive surgery for advanced ovarian cancer. And this technique should be performed in all cases of ovarian cancer undergoing rectal sigmoid resection. Thank you all for your attention.
Thanks so much. 2 questions.
Thank you very much for your presentation. I would have only one question about how did you choose patients who received the idiocyanin green and the patient who didn't? Were they randomized? And how were the randomization? And I've noticed that there is a scale of 1 to 3. Was it in purpose and why? Thank you.
Thank you for your question. Well, as I already said, it is a recent technique, and most of the patients in which the indocyanine green was used before was in colorectal cancer patients and other types of patients. For what regards, we did not randomize them inside our gynecology unit, and with the approval of the ethical committee and everything with regards to the European Institute of Oncology, it was decided that this protocol is applied starting January 2020. So all the consecutive patients undergoing this type of procedure starting that date were being followed with this technique. So when we performed the analysis, we actually retrospectively identified from the medical records the patient that underwent the same procedure before the protocol was applied. And so we then performed the analysis to actually see if is there a benefit of this procedure, because the literature stated, the 2 articles that were in the literature had different results, and one of them stated that there is a reduction to 1.2%, another one stated that there is no reduction and the risk of leak still stays at 9%. So in that case, I mean, it's not cost efficient and it's not patient efficient to use a technique which does not bring any benefit, but my sample of patients is big enough to be able to state that it is actually a technique that should be performed in all cases. So it was not randomized, it was just decided that starting that day, the patient would probably benefit from, based on the data that was related to other types of surgeries.
Yeah, this is a potential source of bias, because you use 2 time frames to compare, so there is eventually always the bias of changing on the techniques over time. So you compared surgeries without indocyanine green, and then there is another curious thing about, we were looking at the multivariate analysis, and you had this time length of surgery, which is a predictor of anastomosis complication, and you were relating it probably to the burden of the disease. So longer surgeries were related to heavier disease, but longer surgeries might be also linked to worse surgeons. So
yeah,
so you never know if the surgeon took longer because he was a junior surgeon doing it. Okay. So it was not
Thank you for your remark. We actually paid, I didn't mention it, but that was a factor that we took into consideration. And the good thing was that inside the gynecology unit, the personnel and the team, the surgical team was the same during this whole time, and the surgeries performed were exactly by the same professionals. So they were not various doctors operating. So this way we kind of removed the human bias. So we could state that it was not influenced by the experience of the doctors, because the same team was operating on these patients. Thank you.
It was the same question.
About how bad the surgeon was.
Was it the same
No,
question?
about the randomization. I mean, the method.
About
section.
randomization,
Yeah, it was the same.
Okay, and we're moving for the last speaker, Giuseppe Salfi, who's going to tell us about advances in differentiating between mass-forming chronic pancreatitis and pancreatic ductal adenocarcinoma. Thank you.
Can I ask you how to go forward and backward? I will just use this one. All right, thank you. Hello, everyone. Thank you so much for having me here. My name is Giuseppe Salfi. I'm a final year MD candidate at University of Milan Bicocca. And I'm presenting something different from what we've seen in the previous presentation. This is a review I've been writing with the support of some other medical students from across Europe and Middle East, with the guidance of Dr. Antoine Brustani from Cleveland Clinic in Ohio. And the title is this one, Advances in Differentiating Between Mass-Forming Chronic Pancreatitis and Pancreatic Ductal Adenocarcinoma. So, as most of you surely know, one of the two main diseases I'm focusing on is pancreatic ductal adenocarcinoma, which accounts for 80% of pancreatic cancer, and it's an extremely deadly cancer, which is part of the so-called big killers of cancers. And the deadly, extremely high mortality rate of this cancer is related to the fact that the vast majority of the patients that receive this diagnosis are actually in a very advanced stage of the disease, and so they cannot undergo surgical intervention. But the purpose of this slide is to have a look at the risk factors of the tumor, and two major non-genetic risk factors for the disease, cigarette smoking and most importantly heavy alcohol intakes, are indeed the same drivers of chronic pancreatitis, which is an established, very important risk factor for a tumor itself. And to add of all these, although atrophy is the main feature of chronic pancreatitis, in a relevant percentage of the patients with chronic pancreatitis, we can see the development of the formation of masses inside the pancreatic parenchyma. And so this makes it very difficult to distinguish between a benign inflammatory form of disease and the actual carcinoma, since the clinical presentation and imaging findings are very similar, and this leads to a big percentage of patients receiving a misdiagnosis, which can lead either to major pancreatic resection for a patient with a benign disease, or even probably worse, to patients that have a disease that is in a surgically resectable stage that do not undergo surgical resection, which is just giving them kind of a death sentence. So the purpose of the review is to sum up what is the most effective way to distinguish between the two diseases, trying to keep a focus on what is more new, what is more effective, and what are the recent advances in the field. So the differential diagnosis between the two pathologies still relies a lot on imaging findings. The main techniques that are applied are endoscopic ultrasound and computed tomography, and secondly also cholangiopancreatic magnetic resonance. So I won't go through all these, but the main features, the main differences between the two diseases can be found in the dimension of the mass, the margins of the mass, the number, the diffusion, the location of the calcifications. There are some specific signs that can be evaluated through CT or magnetic resonance, which are duct penetrating sign for the pancreatitis, and the double duct sign, so the dilation of both common pancreatic duct and bile duct, which is typical of the pancreatic cancer, while another important measure that can be valued through endoscopic ultrasound is the duct to parenchyma ratio, which is actually higher in the pancreatic cancer. But many other imaging techniques have been studied in recent literature, and they prove to be pretty effective in distinguishing between the two diseases, and they include the study of tissue hemodynamics with perfusion CT, and a very interesting paper another very interesting paper combined traditional CT with digital image texture analysis, and proved to be extremely accurate and effective in distinguishing between the two diseases. another recent and very interesting paper is from a Chinese group that performed some, that was able to develop a machine learning algorithm to distinguish between the two diseases, starting from analyzing MRI imaging. And many other studies pointed out that endoscopic ultrasound could sincerely benefit from the addition, from its association with both elastography and or the usage of means of contrast. I'm talking about gas microbubbles. And of course, the diagnosis of pancreatic cancer and this differential diagnosis between the two diseases relies also on markers. I try to avoid talking about the most known CA99, CA. There are some new advances and potentially usable, applicable ideas to the clinic in both serological markers. So I included the exomal GRIPCAN1. This is actually kind of a disputed. There's some controversies about the usage of this one to identify pancreatic cancer in clinics. And another group, using some metabolomic studies, created this panel of 9 metabolites plus CA99 that was extremely effective, had a sensitivity and specificity both higher than 90% in distinguishing the two diseases. And other markers are applicable to tissue samples obtained from fine needle aspiration biopsy, like KRAS, extremely known, but also LDL receptors. And of course, the combination between imaging techniques and markers is more effective in distinguishing between the two diseases. What I wanted to keep a focus on in this work is that there are some modern, extremely innovative techniques, like these. The first work was performed in Shanghai. It was published in February this year, and they combined their algorithm that analyzed MRI imaging with the known CA, CA99, and they showed a great ability to distinguish between the two diseases. So these all lead to my conclusion, which is that extensive research has been, of course, conducted in the field, and unfortunately, distinguishing between mass-forming chronic pancreatitis and pancreatic ductal adenocarcinoma still remains a big issue, a big dilemma, but some very important starting points can be found in the literature, and it would be very interesting and potentially beneficial for patients to include these into the actual clinical practice. All this without undervaluing the importance of the established clinical practice, clinical imaging, and markers we already know that are extremely effective, but that can potentially benefit from the addition and the contribution given from this advancement. And with this, I thank you very much, and I'm happy to take any questions or criticism.
Is there any question? So I want to thank everyone.
Thank you so much.
Because we really got a very nice broad spectrum of topics with different presentation, and it's very cool to see how deep you have knowledge in the field you are working on, from cells to biomarkers to imaging techniques to technical surgical injections and to all sort of genetic markers and cells, leukemia. It's really what happens. So each one of us is working in a very, very different field, but at the end, the methodology of research, the way of writing a protocol to randomize patients, if it's basic research, how to address the ethical questions about animal experimentation, how to feed animals with specific diets, or so at the end, we all have common points about what we do, and at the end, the common point linking us all is try to combine our medical or pharmacy or dentistry training with the research in the lab or with patients. So thank you to the students who presented, and if you have further questions, you can always speak to them during the coffee break that is kicking off now. So thank you all for your attention. we should be back in about 20 minutes. And yeah. What? Yeah. And when are we announcing the price? After the coffee break. So in 20 minutes, when we are back, please, even the students who are not attending the graduation ceremony, just come quickly here because we will announce the better presentation. So the best presentation prize will be announced just after the coffee break. And for those of you who didn't register, you can all go to the dinner tonight, okay? It's in the... I will tell you the name of the place. It's just nearby. We can go walking. La collina dei Ciliegi. Ciliegi. Yeah, one chance out of two.
Yes, La Collina dei Ciliegi is the name of the restaurant.
Yeah, there it is. So, 7:30. The restaurant? 20 minutes.
Okay, you are welcome back in 20 minutes for the graduation ceremony.
C'est vraiment à côté. Comment on switch Qu'est-ce que tu veux? Je veux montrer ça. Ah, il faut demander. C'est le gars en haut, mais je pense qu'il est au café. Can you just put the map, please? Yeah, cool.
Can you say that? Hey guys, the dinner place is showing on the screen right now, just in case you want to note it down. Again, everyone is welcome.
Sì. Ci sono un po' di file sopra. Scusa un secondo.
Non sapevamo.
Sì, ho immaginato. Infatti la signora è andata su, ma un po' veloce.
Allora, sul mio l'ha aperto.
No, dice che analizza e corregge. Si fa così. Allora si chiama Impact. Eccolo là, il primo. Devo prendermi la chiave. Sì.
Devo prendersela?
La lascio qua?
Allora, facciamo una bella cosa.
Sì.
Io...
Ma adesso l'ha copiata? Sì.
No, non l'ho copiata.
Ok.
Io la copio.
Ecco, bene.
La lascio sul desktop. Quindi.
Però scusa, qua c'era forse questa pagina qua dietro. Erano tutte le presentazioni
Sì.
forse. Quindi la può mettere lì. Così è...
Purtroppo ho lasciato, stiamo registrando per tutto quello che stiamo facendo, ma non ho un grosso problema.
C'è acceso il microfono, sì.
Infatti,
Ok,
vedi?
bene. Quindi questa la tolgo.
Proviamo per... Ok,
Sì.
quando
Sì.
F5 adesso al momento passo sulla planimetria che avevo dato.
Ok.
E questo invece la estraiamo.
Spelling, sì. Benissimo.
Se avete dei problemi io sono in regia.
Va bene, grazie.